Alright, so I first wash my hands, I provide privacy to the patient, I walk in and introduce myself and tell the patient, hello, my name is Scott, I'm a nursing student with Channel Islands, and I will be doing a head-to-toe assessment on you today. I would ask the patient their first and last name, as well as their date of birth. Then I would also ask them if they've had any allergies to anything, including latex. I would confirm their first and last name with their wristband, and then I would ask them if they can tell me where they are right now. I would ask them if they can tell me what year we are in, and I would also ask them if they can tell me why they're in the hospital today. So why are you in the hospital today?
Stomach pain.
Stomach pain. Okay. When did that stomach pain start?
This morning.
Okay. Does anything make it better or worse?
Drinking water makes it better.
Okay. Does anything make it worse?
No.
Okay. What does the pain feel like?
Kind of a burning.
Okay. And then on a scale of 0 to 10, 0 being the worst pain, or 0 being no pain, 10 being the worst pain you've ever had, how bad would you say the pain is?
It's about a 5.
Okay. And where in your stomach is that pain? Right over the middle?
Yeah.
Okay. And then have you had any sort of treatment for it yet?
No, not yet.
None? Okay. So I'll keep that in mind. So I was able to assess that the patient was ANO times 4. I didn't note any distress. The mental status seemed within normal limits, and there was no slurred speech. So now I would do their vital signs. So I would do their blood pressure with an appropriately sized cuff. I would get their respiration rate as well as pulse rate. I would do the pulse radially. I would get an O2 stat on the finger. And then I would take a temperature sublingually, and I already assessed their pain. So now I'm going to move on to the head. I would elevate the head of the bed if it's not too uncomfortable with the patient. So if it is uncomfortable, I ask the patient to let me know. Okay. And first, I just visually inspect the head, looking for wounds, lacerations, abrasions, lesions, discolorations, bruising, anything like that. Don't see that. Ask the patient, have you had any head pain recently? Hopefully not.
No.
Okay. And then, so if that's the case, I would then palpate the head, looking for crepitus, deformations, anything like that. Look at the back of the head, don't see anything there. I would then check the ears, looking for secretions, as well as wounds, lacerations, discolorations, anything like that. I'd ask about hearing aids, and if the patient is able to hear adequately. I would then move on to the face, first visually inspecting wounds, lacerations, abrasions, lesions, discolorations, bruising. I would ask the patient to puff out their cheeks, smile, and frown. And then I would ask the patient to clench their jaw and feel their masseter and temporal muscles. Then I would ask the patient to close their eyes and tell me when they feel me touch each part of their face, which is assessing for their sensory. So if they're able to do all those tests, then their cranial nerves 5 and 7 are intact. So now I'll move on to their eyes. So I first check their pupil size before shining the light in. I'd have the patient open their eyes if they could. And then I would shine the light in one eye at a time, just looking for the size as well as the pupils constricting consensually. Then I'll move on to the cardinal fields of vision. So go in the 6 directions, just asking the patient to track the tip of the pen without moving their head. And then I move towards their nose. And then lastly, I ask the patient to look off into the distance. And then on the count of 3, look at the tip of the pen. And I just watch the pupils constrict and the eyes accommodate towards the pen. So if they're able to do all that without any issues, then cranial nerves 3, 4, and 6 are intact. Now I'll look in their nose, just looking for nasal flaring as well as any mucous membranes. Everything looks pink and moist in there, so that looks good. I would ask them if they've had any issues smelling anything recently. That would assess cranial nerve 1. Now I'll move move on to their mouth, looking at cyanosis. I don't see any cyanosis around the mouth. I would look in the mouth, looking for proper dentition, as well as any wounds or lacerations in the mouth. Don't see anything in there. The mucous membranes look pink and moist. So now I would ask the patient to stick out their tongue and say ah, looking for the uvula to retract. I would ask the patient to stick out their tongue and move it side to side. I'd also ask them to swallow. If they're able to do all of that, and cranial nerves 9, 10, and 12 are all intact. I'd have the patient shrug their shoulders. That would assess cranial nerve 11. So far I've assessed cranial nerves 1, 3, 4, 5, 6, 7, and then 8. I can assess, they said they could hear adequately, so I can assess their balance later on. And then 9, 10, 11, 12 I already assessed. So now I'll move on to the neck. I first look visually for any abnormalities. I would, if possible, get a carotid pulse on each side, just to make sure that it's present. And then I palpate the lymph nodes and the thyroid. Now I'll move on to the chest. So I would uncover the patient's chest if they're okay with that. So do that. First, visually inspect for any wounds, lacerations, abrasions, bruising, discoloration, any chest tubes, any scars, anything like that. Then I'm going to listen to heart sounds first. So first I'll listen to the aortic heart sound, which is in the second intercostal space on the right side of the sternum. Then the pulmonary, second intercostal space, left side of the sternum, and the tricuspid, fourth to fifth intercostal space, left side of the sternum, and the mitral, midclavicular, fourth to fifth space. And here I'd also get an apical pulse for 60 seconds. I would note any abnormalities that I hear. Hopefully I don't hear any. I would note the rate and rhythm and note whether or not the rate and rhythm of the heart is regular. Then I move on to the breath sounds. So I would start supraclavicularly on each side. Just ask the patient to take a deep breath in each location. Just avoiding bony prominences here. And get a couple on the side. I would note any abnormalities that I hear in breath sounds, if I do hear any, and then note the rate and rhythm of breathing. Now I'll move on to the abdomen. So I'll cover the patient's chest back up, and I'll lift the patient's abdomen. While I'm doing that, I'll ask the patient if they've had any abdominal pain, which they said they did. We already discussed that, so I'll be careful about that. I'll ask when their last bowel movement was. I'll ask if they vomited recently. And then while I'm on the subject, I'll ask when the last time they avoided urine was. So first, visually inspect for any abnormalities, wounds, lacerations, abrasions, lesions, discoloration, bruising, scars, surgical sites, or colostomy bags, anything like that, or tubes. If you see a colostomy bag. So visually inspected, and I'm going to auscultate the 4 quadrants, listening for bowel sounds. Do 1 quadrant at a time, and then as soon as I hear a bowel sound, I'll move on to the next quadrant. Okay, 4 quadrants, then I'll flip my stethoscope around, and I'm going to go down the midline, listening for a bruit, which would indicate an abdominal aortic aneurysm. After I do that, I would note what I hear, and then I'll palpate, just being extra careful if the patient is in pain about my palpations. So I'd be looking for guarding, rigidity, and rebound tenderness, going to each quadrant. And then I would go epigastrically, as well as suprapubically. And then I would just really quickly visually look at the GU, looking for any abnormalities with the skin, any Foleys, anything like that. Don't see that. So now I'll assess the patient's arms. I'll first visually inspect for any wounds, lacerations, discolorations, bruising, IV sites, which I note here. pulses bilaterally. Make sure that they're equal. I'll test the patient's grip strength bilaterally, so I'll have him squeeze my fingers, and I'll assess his cap refill bilaterally. Make sure that's equal. Then I'll test the active and passive range of motion for the patient, so I'll have them flex their elbows, and then I'll have them do it against resistance to make sure that they're able to do that. And now I'll move on to the patient's legs. So, first, visually looking for any wounds, lacerations, discoloration, bruising, anything like that. I'll pay special attention to the calves and calcaneal area because they're sites of breakdown, looking for redness, swelling, anything like that. I'll also assess their temperature on the back of their calves with the back of my hand just to assess for any heat. Okay, don't see that. I'm going to palpate for edema. Don't feel that. Okay, and I'm going to get some pedal pulses bilaterally, make sure that they're equal, and then get cap refill bilaterally. I'll have the patient lift their legs if they can do that, just to test their range of motion there. And then I'll have the patient push their feet down and up, and then also do it against resistance. And then I'll assess the patient's back. So, let's see. Might be tricky with one person. So, I would have someone help me roll the patient, if possible. Have my assistant come over and help me with that. If you wouldn't mind just rolling this patient for me. So I'm first visually inspecting for any skin breakdown, any wounds, lacerations, discolorations, bruising, abrasions, anything like that. Don't see any. I'm going to pay special attention to the scapula and sacral area. They're common sites for breakdown. And I'm going to get some more breath sounds. I'm just going to ask the patient to take a deep breath in each location. I'm going to avoid bony prominences. Just listening for those breath sounds. Okay, I would say that the patient's lung sounds sound clear bilaterally. Thank you. I would say the patient's lung sounds sound clear bilaterally, and note the rate and rhythm posteriorly. And then if the patient is capable, I'd have them stand up. I would assess their gait by having them walk across the room and back. And then I'd have them close their eyes, and I would assess whether or not they're swaying, which would continue my tests of cranial nerve 8. And then if possible, if we have a Snellen chart, I would have them look at that to assess cranial nerve 2. And then I would ask the patient if there's anything else they need other than that. If not, I'd put their bed in the lowest position and wash my hands and be done.